I'm Dr. Farina, and today we are going to discuss cholecystitis and pancreatitis on its pathological basis. So what is cystitis or itis? Itis is something which is inflammation. So we will discuss the inflammation of gallbladder, the inflammation of the pancreas. It could be acute, it could be chronic. Inflammation of the gallbladder may be acute, chronic, or acute superimposed. Maybe chronic gallbladder infection हो, osteoporosis को superimposed infection आ जाए, so that could be one of the entity, and almost always occurs in association with gallstones. But not necessary. Somehow, somewhere there are situations जब gallstones नहीं होते, then we call it acalculous cholecystitis. And there are certain other reasons which is with it. Without gallstones, without any stones, inflammation milki hai gallbladder. So how to label it? Is it acute, chronic, or acute and chronic? So when you know the morphology, when you know the clinical signs and symptoms, then you can label, is it acute cholecystitis, chronic cholecystitis, or acute and chronic cholecystitis. Okay, one more thing, for acute cholecystitis, you will look for the signs and the symptoms with which a patient presents. And to confirm your diagnosis, you will go for radiological investigation, and along with radiological investigation, there are methods when you go histological interventions. So what is acute cholecystitis? Acute cholecystitis is something when the gallbladder usually is enlarged and tense, and it is bright red or blotchy, violaceous in color. Why are we discussing the morphology here? Look, when there is a cholecystitis, if you people have read, there is intense severity pain in the right hypochondrium and in the epigastric region, which has a tendency to radiate towards the back and towards the right shoulder as well. So these are the signs and symptoms when a patient comes to you with prostration, with intense abdominal pain, with guarding tenderness, with nausea, vomiting, and he presents with these signs and symptoms with emergency, usually in emergency. So much intense that patient land up in emergency. So now we will discuss what's the morphology. If we look, and the ultimate reason and ultimate outcome क्या होता है इसमें, that the patient has been advised for cholecystectomy, removal of the gallbladder. So when you open up, so it will look like this. So upon visualizing this structure, a surgeon can say it's an acute cholecystitis. Why? Because it is tense, enlarged, bright red or blotchy or violaceous in color. If you see this color, can you imagine? Can you appreciate it? It is large, tense. You can see the glistening over it. The glistening structure will show that it is tense. This is something tense. Some of the hyperemia you can see here. You can see a violaceous stage here. You can see some yellow pigmentation. There is subserosal hemorrhages. So this is what? This is subserosal hemorrhages. Okay. And the serosa is frequently covered by fibrinous or in severe cases fibrinopurulent exudate. So why does the fibrinous material come? Fibrinous material come from the hemorrhage that it has got in the subserosal area. So on open surgery, or when the surgeon is planning for cholecystectomy, the structure they can label, is it acute cholecystitis or a chronic cholecystitis, or acute and chronic cholecystitis. Now when we will discuss what happens in chronic cholecystitis and what happens in acute and chronic cholecystitis. Just remember this picture, this is for acute cholecystitis, and you can define it very well if you see this picture, that it is large, tense, it could be tender. That's why it's very, very tender, and patient will present with the extreme tenderness and severe pain in this area. And there you can see violaceous stage as well. There you can see a subserosal hemorrhage as well, and it is covered with the fibrinous or fibrinopurulent exudate as well. Okay. Now this is a look at the fibrinous material over here, the glistening, the shine. Okay, but this is also a picture of acute cholecystitis which has been removed with laparoscopic procedures. In 90% of the cases, They present often obstructing the neck of the gallbladder or the cystic duct. Why? The gallstones. What can obstruct the duct? It's the gallstone which can obstruct the duct. In mild cases, the gallbladder wall is thickened, edematous, and hyperemic. Remember one thing, whenever there is inflammation, either in the gallbladder or in the pancreas, you have to remember the signs and symptoms that you have learned in general pathology of the inflammation, which is ल्यूबर ल्यूबर होता है, उसमें कैलर होता है, डॉलर होता है, which is pain, tenderness, redness, and loss of function. ठीक है, तो these 5 signs and symptoms will come along with any of the inflammation, and that's going to imply over the gallbladder inflammation, over the pancreatic inflammation. The first thing that you will see is the sign for all 5 signs of the inflammation, with edema and with hyperemia, with loss of function, with tenderness, and with redness. The gallbladder lumen is filled with cloudy or turbid bile that may contain fibrin, blood, and frank pus. Now, you should know what a usual gallbladder carry in it. What's the normal thing? The normal thing is the bile. The bile is of olive green in color. So when it is filled with a cloudy, turbid bile, this you can visualize on ultrasounds as well. When if you happen to read any of the ultrasound report, you can see whether they have labeled it as a, what's the color of the secretion they have labeled, what's the color. So when you see the color, so you can imagine and you can interpret yourself, is it normal, is it abnormal, is there any sign of inflammation, is there any sign of acute inflammation or chronic inflammation on the basis of the edema they report, or it is shrunken, or what's the status, is there gallstone present or not. So you should know what gallbladder carries in it. It carries bile, which is olive green in color. It could be yellow brown in color. But here you see in acute cholecystitis, what we are seeing, the lumen is filled with a cloudy turbid bile that may contain fibrin, blood, and frank pus. Achha. Now discussing what else can happen with the gallbladder along with cholecystitis. What else? It can end up into an empyema. It can end up into a gangrenous cholecystitis and also acute emphysematous cholecystitis. So what is empyema? When the contained exudate is mostly pus, it is empyema. What we discussed here, that it may contain fibrin, blood, and frank pus as well. Now, the frank pus is so much that it has obscured fibrin and blood in it, and it has turned into empyema of the gallbladder. So come the gangrenous cholecystitis. In more severe cases, the gallbladder is transformed into green-black necrotic organ. That means the inflammation has reached that intense point that the cells has gone into necrosis and it has turned into green-black. Now, upon your general knowledge, you know, when gangrene happens, what's the main cause behind? It's usually ischemia. So think about it by yourself, that if they are saying gangrenous cholecystitis, this means it has happened from the first step of inflammation that must have caused edema, intense edema, and after intense edema, it must have caused some of the ischemia because of obstruction into the vessels. And when those vessels being obstructed and there is impaired blood supply, that will lead to gangrenous cholecystitis. Okay. Now the third thing is acute emphysematous cholecystitis. The invasion of the gas from forming organism, notably Clostridia and coliforms. If these organisms get into the biliary tree, it can cause acute emphysematous cholecystitis because these are the gas forming organism. From where does it comes from? If you have an idea about it, what happens when there is a gallstone? It can pass into the common biliary duct, and it can then slip down up till the intestine, and it can cause ileus. That is biliary ileus. It can obscure and form fistula over there as well. And from the gut, there become a passage which can enter into the biliary tree. So then from that point, organism like Clostridia and coliform can ascend up to the biliary tree into the gallbladder and can cause acute emphysematous cholecystitis. Now the histology. You have seen this picture on table. Okay. Now you have sent the specimen for histology. The usual pattern, if it is an acute inflammation and acute cholecystitis, we are talking about the acute cholecystitis only. We are not even talking about the gallstones. So what is a gallbladder wall look like on histology? Usual pattern of acute inflammation, that is edema, leukocytic infiltration, vascular congestion, frank abscess formation, and gangrene necrosis could happen. So these all signs of inflammation, the all 5 signs of inflammation, you would see in an acute inflammatory type of cholecystitis, acute cholecystitis. There is nothing special, nothing new in it. So what about acute calculous cholecystitis? Acute inflammation of a gallbladder that contains a stone. Now we will categorize it. Is the cholecystitis, which is acute in nature, is due to the gallstones in it or is because of some another pathology? So we will categorize as acute calculus and acute acalculous. So when there is a gallstone in it, what happened? There is acute inflammation of gallbladder that contains a stone in term acute calculous cholecystitis and is precipitated by the obstruction of the gallbladder neck or cystic duct. So, to your knowledge, you must have seen people who have gallstones, but they are asymptomatic. They never turn into symptomatic patients, and they are happy with it. They won't get into any intervention. They won't get their gallbladder removed because they are not having any kind of sign and symptom. Why? The sign and symptom usually arises when those stones start obscuring the drainage passage or when those stones get slipped down into the biliary tree. So acute inflammation of the gallbladder which contains a stone is termed acute calculous cholecystitis and is precipitated. Like the patient will come into ER when he has a precipitation of the inflammation, when he has precipitation of signs and symptoms, pain and tenderness because of obstruction of the gallbladder neck or cystic duct. Got it? So the major complication of the gallstone, this is one of the major complications and that need to be treated with cholecystectomy. Now talking about the clinical feature that you must know, there is a biliary pain. What is biliary pain? It's an intense colic-like pain and there is severe tenderness, guarding. Patient may get into abdominal obstruction. Okay? And the one more thing you should know, what they have written, epigastric region that lasts for more than 6 hours. It's a severe kind of pain that can last for hours as well, and it radiates to the right shoulder with fever, nausea, leukocytosis, and prostration. Remember, prostration is so pathognomic that when you see a patient in ER, you can label him as he must have got colic pain. Cholecystitis, he must have got pain because of cholecystitis. So mild attacks usually subside spontaneously over 1 to 10 days. However, recurrence is common. How does it subside? You will treat the patient with antibiotics, with analgesics, and it gets subsided. Until and unless the stone get obstructed and stone get obstruct the cystic duct or some other region of the drainage. Approximately 25% of the symptomatic patients are sufficiently ill to require surgical intervention. Acute calculous cholecystitis frequently develops in diabetic patients who have symptomatic gallstones. Now, what does this mean? Is that so that all diabetics will get cholecystitis or gallstones? So, what does it mean? Usually what happens, if you have seen a diabetic patient, they are with multiple comorbidities. They must have their cholesterol levels high, they must have their impaired metabolic system, probably they are into metabolic syndrome. So they have underlying situations as well. So it's not necessary that all diabetics get gallstones, but gallstones are associated with the patient's comorbidities. So the laboratory finding, you will get conjugated hyperbilirubinemia. Why? Because of the obstruction it produced at the biliary tree. So this is a picture which shows that this is the area where the pain generates, and this is called Murphy's sign because if you have seen, there is rebound tenderness. When you touch the patient and you remove your hand from there, there is tenderness. The gallbladder walls or the gallbladder itself is so much inflamed, edematous, that it touches the abdominal wall, it produces intense pain, and that pain radiates towards the right shoulder as well. Now the pathogenesis. Why does this happen? What happens? You have read that there is inflammation. So what else happens that causes some distortion, destruction in the gallbladder, and it turned out to be, it can turn into a gangrenous necrosis as well. So there is a chemical irritation. So how does this chemical irritation start? There is inflammation of the gallbladder wall in the setting of the obstruction of the bile outflow. And then there comes a phospholipases. Phospholipases are derived from the mucosa. Phospholipases has the function to hydrolyze the biliary lecithin to lysolecithin, so which is itself toxic to the mucosa. See what happens? There is inflammation, and that inflammation causes the mucosa to secrete phospholipase, and this phospholipase is hydrolyzes biliary lecithin to lysolecithin, and which is itself toxic to mucosa. So it's a sort of vicious circle or the positive feedback mechanism that keeps on carrying on, and it will induce more inflammation and more changes in the mucosa of the gallbladder in acute stage. The normally protective glycoprotein mucus layer is now disrupted, which the function because of these enzymes which has been produced, and exposing the mucosal epithelium to the direct detergent action of the bile salts. So these enzymes along with the bile salts will put the insult towards the mucosa and cause inflammation to be into severity. So also there are prostaglandin release, prostaglandin I and E, which within the wall of the distended gallbladder contribute to the mucosal and neural inflammation. So you have got three things which will enhance the inflammation and which will enhance the acute state of the gallbladder, which is the phospholipases, the release of the phospholipases, the conversion of the biliary lecithin to lysolecithin, the bile salts, and the prostaglandin. So look at this picture. Now you see there, this is an edematous gallbladder wall. This is the first thing that you see in any inflammation, which is edema. So this edema causes distension of the gallbladder. Outside it causes distension. Okay, if you remember this picture, which I showed you earlier, this is what? This is distended. Why? Because of the edema. See, okay, there is distension. And inside what happens, there is increased intraluminal pressure. This pressure increases. It pushes outward. And this is the gallstone, which has obstructed the cystic duct. So there is no space for the bile to be excreted out, and that's why it's causing the inflammation. The inflammation has now started. Why? Because of the mucosa, which releases phospholipases, which hydrolyzes biliary lecithin to lysolecithin, and then release of the prostaglandin, and also the bile salts itself start affecting the mucosa of the gallbladder. Now, acute acalculous cholecystitis, it is about 5 and 12% of the gallbladder which are being removed. As a case of acute cholecystitis, they turn out to be acalculous. Acute acalculous cholecystitis without a stone involvement is thought to result from the ischemia of the cystic artery. So you know what you need. In calculous cholecystitis, there is a stone which obstructs the cystic duct, which obstructs the outflow, which obstructs the biliary duct, which may obstruct the common hepatic drug, common hepatic bile, CBHD. So, but what happens in acalculous? There is ischemia, there is impaired blood supply, and to combat that blood supply, the gallbladder mucosa will react so that it will get all the signs of the inflammation in it, and then all the phenomena which you have read earlier, and prostaglandin release and all. So what are the conditions which causes acalculous type of cholecystitis? Cholecystitis without presence of the gallstone. So these are the conditions when you see there isn't any history of gallstone, there isn't any history of calculus in the patient, and but still his gallbladder seems to be inflamed. So these usually you see in severe dehydration, shock, sepsis, massive transfusion, and other comorbidities like diabetes and vascular injuries and cancer. So what's the basic phenomena they follow? All these situations actually affects the microvascular occlusion and coagulation. So these are the situations where there is phenomena where they can cause microvascular occlusion and hypercoagulable state. Body is in hypercoagulable state. In sepsis, body is in hypercoagulable state. Massive transfusion, body is in hypercoagulable state. In these comorbidities, even in dehydration and shock. So what happened? There is ischemia, local ischemia, and that will lead to cholecystitis. Okay, and that will lead to inflammation of the gallbladder, and it would be of acalculous type. Inflammation, edema of the wall, compromising the blood flow, gallbladder stasis. So what happens when there is blood flow stasis? When there is impaired blood flow, the gallbladder stasis, like whatever the secretions were there, they get stuck in it. An accumulation of microcrystal of cholesterol which forms a biliary sludge, viscous bile and gallbladder mucus, causing cystic duct obstruction in the absence of the stone. Now this sludge which act like a stone, when there were stones, the stone was sufficient enough to obstruct the cystic duct. Now they form a biliary sludge. That sludge will obstruct the cystic duct and there will be impaired outflow of tract. So that will lead to edema and inflammation of the gallbladder. And it's an acute state. Okay. So remember the pathogenesis, what happens in acute cholecystitis, there was a stone that has obstructed the cystic duct. And there will release inflammation of the mucosa, and that mucosa causes release of the phospholipases, which hydrolyzes biliary lecithin to lysolecithin, and there is disruption of the protective layer of the mucosa with bile salts also affecting the mucosa, and also release of prostaglandin I and E, which further enhance the neural inflammation. And what happens in acalculous cholecystitis? There is impaired supply of the blood, oxygen and blood, that lead to gallbladder stasis. And because of that stasis, there is microcrystals of cholesterol, that is the biliary sludge, viscous bile formation, and gallbladder mucus get inflamed and get an insult because of obstruction and biliary sludge formation. And that sludge will obstruct the cystic duct and in the absence of the gallstones. And that will lead to acute cholecystitis but acalculous type. Now the chronic cholecystitis. Chronic cholecystitis may be the sequel of the repeated bouts of acute cholecystitis, but in most instances it develops without any history of acute attack. See, I told you earlier there are few people who have gallstones, but they are always asymptomatic. They never turned up symptomatic because their stones are either they are very small in number or they never obstruct the cystic duct. So they remain asymptomatic. But what happens, their gallbladder or their condition can turn into a chronic stage, and that is because of the acute inflammation that has taken place inside, which was unnoticed, or probably somehow they had some symptoms which was masked by the analgesics and antibiotics they took earlier. So in this situation with cholecystectomy, more than 90% of the cases. Usually E. coli and Enterocolli coli can be cultured from the bile in about 1/3 of the cases. We are talking about the whole chronic cholecystitis, that mostly it is because of the gallstones. Okay. Now the clinical features are the same, that is the recurrent attack of steady epigastric upper quadrant pain with nausea, vomiting, intolerance to fatty food. Because what's the function of bile? It's digest the fatty food. Morphology. Now there comes morphology. You have seen the morphology and read this morphology of the acute cholecystitis, how it was. It was very tense, taut, glistening, bright red in color. Yeah, you also have seen subserosal hemorrhages. Okay, na? Now what happens here? Look at this gallbladder. Remember one thing, chronic cholecystitis is a pathological diagnosis. When a surgeon resects and either open surgery or it's a laparoscopic surgery, when he sees this structure which is fibrotic, contracted, discolored, lusterless, so he can label this as a chronic cholecystitis. The gallbladder has been inserted many times and it has now turned into a chronic stage. So it is a pathological diagnosis. Chronic cholecystitis is a pathological diagnosis. Whenever patient present with acute symptom, you will label it as acute cholecystitis, or it could be acute or chronic, depending upon the period, time, and the initial diagnosis or initial lab reports he has. So morphology, serosa is usually smooth and glistening, but may be dulled by subserosal fibrosis. Remember all basic concept. What happens in any kind of chronic inflammation, you will see sclerosis, fibrosis. Okay. Dense fibrous adhesion may remain as a sequel of pre-existing acute inflammation. On sectioning, the wall is variably thickened and has an opaque gray-white appearance. In the uncomplicated cases, the lumen contains green-yellow mucoid bile and usually stones. The mucosa itself is generally preserved. So whatever is happening on the wall, which is sclerosed, which is discolored, and one more thing, it is variably thickened and has an opaque gray-white appearance. It is thickened. Why thickened? Because वहाँ पे fibrosis होता है. Remember also what kind of fluid it will carry. It will carry green yellow mucoid bile. And what was the fluid color in acute, if you remember? It was turbid with fibrin and blood in it. Histology. In the mildest case, like we are talking about the chronic cholecystitis, this has been resected on by surgery. Now you will send this specimen for histology. In the mildest cases, only scattered lymphocytes, the plasma cells and macrophages are found in the mucosa in the subserosal fibrotic tissue. What does it show? Lymphocytes, plasma cells, macrophages, all cells of the chronic inflammation. And in severe cases, there is subepithelial subserosal fibrosis with the mononuclear cell infiltration. So when happen in severe, in mild cases में क्या हो रहा है? सिर्फ wall involve हो रही है और आपको mucosa में there is subserosal fibrotic tissue भी मिल रहा है along with the cells of the chronic inflammation. And in severe cases, there is subepithelial and subserosal fibrosis. The fibrosis is extended up till the level of the epithelium, and there is mononuclear cell infiltration. One more thing which is very important, and it is diagnostic over the ultrasound. Whenever ultrasound abdomen is advised to a patient, so this structure will say it is a chronic cholecystitis. They will label it chronic cholecystitis. The structure is Rokitansky's Aschoff sinuses. What is Rokitansky's Aschoff sinuses? These are the outpouchings of the mucosal epithelium through the walls. What happens? There is chronic insult on the mucosa. When there is chronic insult on the mucosa, they form outpouching. This outpouching is easily seen on ultrasound with bile in it. So this is called Rokitansky's Aschoff sinuses, which is only and only seen in the chronic cholecystitis, either calculus, acalculus, whatever. And you have read it that 90% of the chronic cholecystitis are calculus type. They have gallstones in them. So this is outpouching with bile in it. So this is called Rokitansky's Aschoff sinuses. There is also reactive proliferation of the mucosa, and fusion of the mucosal folds may give rise to the buried crypts of the epithelium within the gallbladder. So this structure, like this sinuses, this sinuses, this sinuses, and this kind of, if you visualize it more on the high power, so this is Rokitansky's Aschoff sinuses with bile in it. So this will show it's a chronic cholecystitis. Now what happens when cholecystitis get worse and is not treated on time, is not treated sufficiently, is been ignored? Bacterial superinfection with cholangitis and sepsis can happen. Gallbladder perforation with local abscess formation, gallbladder rupture with diffuse peritonitis. These are the local complications which you need to counsel your patient that if you won't get it treated, resected right now, you can get into sepsis, cholangitis, which is more severe pain, with gallbladder perforation भी हो सकती है, with local abscess formation, with gallbladder rupture with diffuse peritonitis. So these are some lethal complications. What else can happen is biliary enteric fistula formation. We read earlier that there is acute emphysematous type of gallbladder. So this is what biliary enteric fistula, with drainage of the bile into adjacent organs, entry of the air and bacteria in the biliary tree, and potentially gallstone induced intestinal obstruction. That stone will slip down into the intestine and can cause ileus and obstruction. So with the simple disease, which we think like that gallstone is something very common in our society, and it's very people won't take it so seriously, these lethal complications can happen, and they do occur. There is aggravation of pre-existing medical illnesses with cardiac and pulmonary, renal or liver decompensation. If patient has some other comorbidity, he may get worsen in it. Now, the xanthogranulomatous cholecystitis, the gallbladder has massively thickened wall and is shrunken, nodular, and chronically inflamed with foci of necrosis and hemorrhage. This xanthogranulomatous cholecystitis happens with chronic cholecystitis. You have seen the picture, this one. What I told you, that the wall is thickened, this has discolored, and we read it that there is subserosal subepithelial fibrosis. When there is intense fibrosis because of the chronicity, it can cause uh, it may turn into it may shrunk and become into a nodular structure with chronically inflamed and foci of necrosis and hemorrhages. It is triggered by the rupture of Rokitansky's Aschoff sinuses into the wall of the gallbladder, followed by an accumulation of macrophages that have ingested biliary phospholipids. So these sinuses get ruptured. Look, if you imagine like this, if there is fibrosis around it, what will happen? It will get squeezed and ruptured. When it gets squeezed and ruptured, what will happen? There is accumulation. So जो भी उसका product निकलेगा, how it will get excreted out. Macrophages will recruit over there and they get ingest the biliary phospholipid and they form the xanthogranulomatous cholecystitis. Remember from the word of xantho that there is something with the phospholipids, and granulomatous is something chronic, and cholecystitis is inflammation of the gallbladder. Such lipid-containing cells with foamy cytoplasm are called xanthoma cells. तो ये macrophages जब इसको engulf करेंगे इसके product को and they release phospholipids in it, so this is called xanthoma cells, and the whole gallbladder with these macrophages with these foamy cytoplasm, it's termed as xanthogranulomatous cholecystitis. And this is because of the rupture of Rokitansky's Aschoff sinuses. Severe chronically inflamed gallbladder can have this condition. What is hydrops of the gallbladder? When there is atrophy, this is also a sequel of chronic cholecystitis. Atrophic, chronically obstructed, often dilated gallbladder may contain only clear secretions. So this is hydrops of the gallbladder. Sometimes if you have you will experience in future, you will read some of the ultrasound report, you will see they have labeled it, the secretions in the gallbladder are seen clear. It's not even turbid, not even yellow, and not even yellow, olive green in color. They can't see the color, but they won't say it's turbid or it's something unusual. They say it's clear secretion. So that shows that gallbladder. Then you will look into the structure and wall, what they have labeled about the structure and wall of the gallbladder. It should be atrophic, it should be shrunken, because hydrops of the gallbladder occurs with atrophic, chronically obstructed form where it stays distended and the secretions turn out to be clear. Now we'll discuss pancreatitis. Pancreatitis is inflammation of the pancreas. This is acute pancreatitis is a reversible inflammatory disorder, and there you will see edema. The same all signs of inflammation would be there with fat necrosis and hemorrhagic parenchymal necrosis. So remember this thing whenever there is pancreatitis. One more thing, acute pancreatitis is a very severe condition. It's a medical emergency. It can get recovered and it's reversible. But if left untreated, undiagnosed, and impaired treatment agar hota hai, so it is lethal and it could be fatal. So what happens in acute pancreatitis? There is edema. Along with all signs of inflammation, there is fat necrosis and hemorrhagic parenchymal necrosis. So you should remember its incidence is 10 to 20 per 100,000, and it is 80% of the condition is because of the biliary tract diseases and mostly gallstones. The next comes the alcoholism. Roughly 5% of patients with gallstones develop acute pancreatitis and gallstones are implicated in 35 to 60% of the cases overall. So 5% of the patients who have gallstones can land up into acute pancreatitis. And in terms of acute pancreatitis, when you rule out the 35 to 60% patients have the causes, the cause would be gallstones. So these are the reasons, these are the list of the ecological factors of acute pancreatitis. In this, gallstone is the most common cause. Then comes the alcoholism, And along with alcoholism, you should know in metabolic, it could be hyperlipoproteinemia. Hypercalcemia is one of the ecological factors that you should know, because calcium is responsible for converting trypsinogen into trypsin. So whenever there is hypercalcemia, it can cause acute pancreatitis. Drugs, there are many, few more drugs, but remember azathioprine. Genetic mutation, 5 to 6 genes are there which you should know and learn, which are impairing the trypsin activity and which are not inhibiting the trypsin activity. They can lead to pancreatitis. Now the mechanical causes, you know, okay, all of the along all of these causes, the mechanical one is the gallstone obstruction is the one of the most common cause. Along it could be trauma, iatrogenic causes. Vascular may like shock, atherombolism, polyarteritis nodosa. An infection, remember, mumps and Coxsackie virus can cause acute pancreatitis. Now, the pathogenesis, acute pancreatitis results from inappropriate release and activation of the pancreatic enzyme, which destroy pancreatic tissue and elicit an acute inflammatory reaction. If you remember, I said in acute pancreatitis is what? It's edema along fat necrosis and hemorrhagic parenchymal necrosis. So fat necrosis shows कि यहाँ पे कोई enzymatic activity हो रही है, ठीक है ना? And hemorrhagic parenchymal necrosis also shows कि यहाँ भी parenchyma को कोई चीज खराब कर रही है, ठीक है? So the pancreas is what? Pancreas is exocrine and endocrine in nature. So it will release some enzymes. It will also acute in chronic, either chronic pancreatitis can cause diabetes mellitus as well. So there is enzymatic activity, inflammation, and impaired enzymatic activity. Trypsin, which is a proenzyme, activation of other is responsible for the activation of other proenzymes such as phospholipases and proelastases, which then degrade fat cells and damage the elastic fibers of the blood vessel. So when it damages the elastic fiber of the blood vessel, it can cause hemorrhage, necrosis, and gangrene as well. So trypsin also act on the prekallikrein, which is an activated form, and thus bringing into play the kinin system, and by activation of the coagulation factor 12, the clotting and complement system as well. So you have got this thing which is affecting the blood vessel elastic fiber, like the activation of the proenzyme, prophospholipases, proelastases, and activation of the trypsin on the kinin system and the clotting complement system. So there it will affect the blood supply as well, the clotting and complement system. The resulting inflammation and in small vessel thrombosis causes damage to the acinar cells. So this is the main pathology behind. How does an acinar cells get damaged? It gets damaged because of the enzymatic activity and because of the small vessel damage, amplifying the intrapancreatic activation of the digestive enzyme. Remember this picture, we say for acinar cell injury, there are three possible causes, that is duct obstruction, acinar cell injury, direct acinar cell injury, and defective intracellular transport. Duct obstruction could be of because of many causes that we are going to discuss in the next slide, and that causes interstitial edema, impaired blood flow, ischemia. Remember, whenever there is intense edema, inflammation, that will lead to distension of the organ, that will lead to obstruction into the blood flow, and that will lead to ischemia, and that ischemia will cause acinar cell injury. What happens in direct acinar cell injury? The most common cause is the alcohol. Alcohol itself produces oxidative stress and some other phenomena as well that causes acinar cell injury. It could be because of the drugs, trauma, ischemia, and viruses, and that releases intracellular proenzyme lysosomal hydrolases, and that will lead to acinar cell injury. So what other possibility is this? There is another possibility of defective intracellular transport. So whenever there is defective intracellular transport, there are multiple causes. We are going to discuss every cause next. Just to remember this picture and this flow chart, this will help you remember the etiology. It could be duct obstruction, it could be acinar cell injury, it could be defective intracellular transport. So these three can cause acinar cell injury, and with acinar cell injury, there is activated enzymes which are not getting inhibited by any of the factors, and by they are not guarded by anything. So these activated enzymes can cause like proteolysis है, fat necrosis because of the lipases, hemorrhages because of the elastases, because these elastases were acting on the blood vessel wall, and that causes hemorrhage because blood vessel wall get fragile. So you will get fat necrosis, you will get proteolysis, you will get hemorrhage with interstitial edema, and that all lead to acute pancreatitis. To cause acute pancreatitis, to happen acute pancreatitis, you need there should be SNR cell injury, and there are multiple factors behind. Along with SNR cell injury, there are unguarded, unprotected enzymatic activity that itself auto digestion start हो जाएगी यहाँ पे ना, auto fat necrosis, proteolysis, protein degradation start हो रही है, inflammation है, edema है, with hemorrhage है, and these all factors lead to acute pancreatitis. So what we expect in obstruction? We were saying there could be duct obstruction. Duct obstruction is the most common cause. It could be due to gallstone, biliary sludge. Where biliary sludge happened? It happened in the chronic cholecystitis, acute cholecystitis, which was acalculous type. There you get biliary sludge. In acute calculus type, it is gallstone. Periampullary neoplasm, it could be pancreatic cancer. Choledochosis, which is a congenital cystic dilatation of the common bile duct. It could be because of the parasite like Ascaris lumbricoides and Clonorchis sinensis, and it could be pancreatic dialysis. So these are the common causes which can obstruct the pancreatic duct, and because of obstruction, what happens? Look at the pathogenesis. What happens? Due to obstruction, rises the intrapancreatic ductal pressure and lead to the accumulation of the enzyme-rich fluid in the interstitium. Although most pancreatic enzymes are secreted as inactive zymogens, but what happens when there is accumulation of and inflammation at the wall of the pancreas and the duct of the pancreas, that will cause enzyme-rich secretion in it. The lipase is produced in an active form and has the potential to cause local fat necrosis, which lead to dead adipocyte. This dead adipocyte itself is responsible for pro-inflammatory cytokines, edema, inflammation. So there happens a positive feedback mechanism, a vicious circle start that is started with the obstruction of the duct, inflammation and dilatation of the duct. Itself produces enzymes in it, and that enzyme causes the necrosis, fat necrosis, and because of the fat necrosis, you will see dead adipocytes, and these adipocytes will lead pro-inflammatory cytokines, which causes further edema and inflammation. So leading to SNR cell injury. So remember what happens? There is accumulation of the dead adipocyte, and that dead adipocyte causes secretion of the cytokines and enhancing the inflammation. Now, the primary SNR cell injury, which is which lead to release of the digestive enzymes because of inflammation, there is autodigestion of the pancreatic tissue. So pancreatic cell SNR cell injury, you remember there were the factors like alcohol consumption, like drugs, like medications, which were causing primary SNR cell injury, and that lead to the accumulation of the enzyme and autodigestion of the pancreatic tissue. There is an oxidative stress, and that releases free radicals in the SNR cells, leading to membrane lipid oxidation and the activation of transcription factor, including AP1 and NF-kappa B, which in turn induces expression of the chemokines that attract mononuclear cells. What they can ask you, the pathogenesis behind primary SNR cell injury. So the pathogenesis behind primary SNR cell injury, there is autodigestion of the pancreatic cell tissue. Why? Because of the oxidative stress. And what happens in oxidative stress? There is a release of the membrane lipid oxidation. There is a release of the AP1 and NF-kappa B factors that causes membrane lipid oxidation, and this will cause further recruitment of the inflammatory cells and like mononuclear cells, and there is insult to SNR cells, and that lead to injury of the SNR cell. Remember one thing, whenever there is high calcium, it will cause enhanced conversion of the trypsinogen to trypsin, and when there is low calcium, trypsin remains inactive. So all the metabolic conditions can cause SNR cell injury because of conversion of the trypsinogen into trypsin. Okay, and trypsin is responsible for protein digestion. So there will be autodigestion. There will starts an autodigestion. Defective intracellular transport of proenzyme within the SNR cells. There is a defective intracellular transport. The enzymes, these are not transported well, and the cause could be alcohol consumption. What happens in alcohol? Alcohol consumption transiently increases contraction of the sphincter of the odi, and chronic alcohol ingestion results in the secretion of the protein-rich pancreatic fluid that leads to deposition of insatiate protein plugs and obstruction of the small pancreatic duct. Okay, so there is a thick protein plug at the which causes obstruction of the duct, and that will lead to inflammation and accumulation of the protein-rich pancreatic fluid. Also, alcohol is responsible for direct toxic effect on SNR cells and all induce oxidative stress. Alcohol, if they ask why alcohol is causing acute pancreatitis, so why alcohol is chronic consumption of alcohol is related with pancreatitis. So these three effects, like it also affects on the contraction of the sphincter of odi, it increases its contraction. It's increasing the contraction of the sphincter of odi, and in chronically alcohol abuse patient, there is a secretion of protein-rich pancreatic fluid that leads to deposition of thick protein plugs and obstruction of the small pancreatic duct. So when the outlets are all obstructed, what happened behind? It will get increased intramural pressure, it will get edematous, it will get thickened, it will get accumulation of the enzymes, and those enzymes will start autodigestion. Those enzymes which need to be secreted into the intestine are now accumulated there, and they start their functions. Also, alcohol has direct toxic effect on SNR cells. This is very important to remember. Do remember that what are the effects that alcohol produces and why it is so lethal to pancreas. And alcohol induced oxidative stress. What happened in oxidative stress? The same phenomena. If you remember here, it will release API and NF-kappa B, which induce expression of chemokines and attract more mononuclear cell, more inflammation in a chronic type. Okay? Like we discussed earlier, there are many causes. One of them are alcohol, metabolic disorder in which hypertriglyceridemia, hypercalcemia, genetic lesions we are discussing in the next slide. There are 5 to 6 genes which are responsible for causing pancreatitis because they disrupt the function of trypsin. They will not alter the function of trypsin, they will not guard the function of trypsin, and there will be autodigestion. Medication like furosemide, which is a diuretic, azathioprine, which is a immunosuppressant agent, and 2,3-dideoxyunosine, which is a drug for HIV. So these 3 drugs are responsible, can cause pancreatitis, in which furosemide is a very commonly taken drug. Azathioprine and 2,3-dideoxyunosine is not that much common in our setup. Also estrogens. So HRT taking women should also be considered if they are having some sort of signs and symptoms related to pancreatitis. One more thing of trauma. Trauma can cause pancreatitis. What type of trauma? It could be iatrogenic injury, like in surgeries, or endoscopic retrograde cholangiopancreatography sort of procedures. Ischemia of SNR cell caused by the shock, vascular thrombosis, emboli, vasculitis. Infection we discussed, mumps and Coxsackie virus can cause pancreatitis. So these drugs, CFTR, PRSS1, SPINK1, CASR, CTRC, CPA1, you have to memorize their function. This is the function of CFTR, like what? It causes loss of function mutation, alter fluid pressure, limit bicarb secretion, leading to thick secretion of the fluid and duct obstruction. So whenever there is this gene in mutation, the same thick secretions get accumulated and will obstruct the duct. And with PRSS1 gene mutation, there is gain of function mutation which prevent self-inactivation of the trypsin. So when there is gain of function of PRSS1, trypsin will not get disrupted, inactivated, and will continue its autodigestion and proteolytic activity. SPINK1 gene, there is mutation and it's a loss of function with increasing trypsin activity because it's an inhibitor to trypsin. And CSR is a membrane-bound receptor that senses extracellular calcium levels. So you have read that hypercalcemia is responsible for pancreatitis because it causes activation of the trypsin. So CASR gene is responsible for this function. CTRC degrades trypsin, protect the pancreas from trypsin related injury. So CTRC gene mutation में क्या हो रहा है, ये वाला function follow नहीं होगा. That's why whenever this CTRC gene get mutated, trypsin related injury will be there. So CPA1, it will cause zymogens to activate. Now, the hereditary pancreatitis is characterized by recurrent attacks of severe acute pancreatitis, often beginning in the childhood. Remember, how will you label it hereditary? These genetic mutations only, or symptoms कब से start हो जाएंगे? Symptoms will start in the childhood. Ultimately, it will lead to chronic pancreatitis. The disorder is genetically diverse, but the shared feature of most forms is a defect that increase or sustain the activity of the trypsin. Why? Because सब में आप देखें ज़्यादातर में क्या है, trypsin की activity either inhibit नहीं हो रही या फिर there is gain of function mutation तो trypsin की over activity. ठीक है? Morphology of if you hello
मैडम टाइम एंड हो गया है.
मुझे बस 5 मिनट और दें, ये हो जाएगा. इंपॉर्टेंट टॉपिक है, हमको समझना जरूरी है.
ठीक है मैडम.
अच्छा, we'll discuss the morphology. Morphology में आप वही याद रखें कि there is microvascular leakage causing edema. All signs symptoms of the inflammation आएंगे with necrosis of the. You read in the first slide there is edema, fat necrosis, and hemorrhagic parenchymal damage or necrosis. So this is what happening when you see the morphology. There is edema, there is necrosis of the fat by lipases, acute inflammatory reactions, proteolytic destruction of the pancreatic parenchyma and destruction of the blood vessels. Why of the destruction of blood vessels? If you remember, क्या हो रहा था? Elastase affect हो रहे थे blood vessels के. ठीक है ना? अच्छा, we'll discuss the histology. Histology mild inflammation में सारी वही mild inflammatory inflammation के symptoms होंगे, and fat necrosis, release of the fatty acids combined with the calcium. Remember this thing. Whenever you see the histology, there could be a fatty acid combined with the calcium to form insoluble salt that impart granular blue microscopic appearance on the to the fat cells. So this is a diagnostic. अगर उस scenario में आपको इस तरह की कोई बात लिख के देते हैं, you can label it as an acute pancreatitis. While in severe cases, there is loss of acinar cells in ductal tissue and islets of Langerhans as well. There is vascular injury, and microscopically the pancreas will look red black because of the hemorrhage with areas of white, yellow, chalky fat necrosis around it. ये पिक्चर याद रखें, यहाँ पे क्या है, हेमरेज हो रहा है और यहाँ पे white, chalky fat necrotic areas आ रहे हैं. हिस्टोलॉजी पे what is this is fat necrosis. यहाँ पे आपको क्या नजर आ रहा है, foamy cells नजर आ रहे हैं. What is happening here? This is necrosis. Necrosis में क्या होता है, recruitment of the inflammatory cells हो जाती है. ठीक है ना? There is intense necrosis over here and there is fat necrosis over here. With combining this picture with the morphology, there is hemorrhage and chalky white areas आपको नजर आ रहे हैं. So this is acute pancreatitis की morphology और histology. Sign and symptoms same है. The intense abdominal pain होगा, severity intense होगी, patient will not be able even to lie down. वो एक prostrated state में बैठा होगा, lean forward होगा, dyspneic हो रहा होगा, और laboratory पे आपको क्या मिलेगा, elevated level of amylase and lipase. So how will you say amylase and lipase के level को आप किस तरह judge करेंगे? अभी हम आगे डिस्कस करेंगे. ठीक है, अमाइलेज एंड लाइपेज के लेवल को आप इस तरह जज करते हैं कि देयर इज अ मार्क्ड एलिवेशन ऑफ सीरम अमाइलेज लेवल ड्यूरिंग इन द फर्स्ट 24 आवर्स. ठीक है, इन एक्यूट पेंक्रेटाइटिस. सिम्टम साइन अगर आपको मिल रहे हैं, एपिगेस्ट्रिक पेन के साथ यूजुअली आता है. सबसे पहले आप अमाइलेज कराते हैं ड्यूरिंग फर्स्ट 24 आवर, इंटेंसली रेज लेवल्स आपको मिलते हैं, फॉलोड बाय लाइपेजेस. लाइपेजेस स्टार्ट होते हैं रेज बिगिनिंग, जो फर्स्ट सिम्टम्स उसको आया होता है उसमें 72 to 96 आवर्स तक लाइपेजेस एलिवेटेड रहते हैं. ठीक है, विद ग्लाइकोज यूरिया, हाइपोकैल्सीमिया एंड रेडियोलॉजी. सीटी स्कैन इज रिकमेंडेड टू, it's a diagnostic procedure. CT abdomen is a diagnostic investigation for acute pancreatitis. Treatment is keep the patient nilpal oral with analgesics and with IV fluids. The prognosis 5% with severe pancreatitis die in the first week of the illness. ठीक है, ये याद रखना कि if it's remain untreated तो 5% of the patient will die. because of the pain, because of the shock, because of the sepsis, because of the autodigestion, because of the hemorrhage, ischemia, and enzymatic activity. Okay? Also, it can lead to acute respiratory distress syndrome, acute renal failure. It can also cause pancreatic pseudocyst formation, pancreatic abscess formation, and 40 to 60% of patients will get infected with gram-negative organism from the alimentary tract as well. So, its prognosis is not good if remain untreated. But remember, the first line, acute pancreatitis is a reversible condition if treatment appropriate treatment has been given on time. So poor prognostic factors क्या हो जाते हैं when there is systemic organ failure and necrosis in the pancreas. This is a comparison picture. इसको जल्दी से ब्रीफ कर लेते हैं. Acute pancreatitis की पिक्चर आप देखें, इसमें क्या हो रहा है, SNR सेल अगर इंजरी हो भी रही है तो it's getting back to its normal function. Look at it. ठीक है, there is an acute inflammation, there is a vascular injury, there is a proteolytic enzymatic activation, there is inflammatory mediators, and but still it's an acute attack. तो ये SNR cell regain कर रहा है. What happens in chronic inflammation? You will get TGF beta, you will get oxidative stress, there is proliferation of stellate cells, and there is collagen secretion. These all factors will cause fibrosis. When there is fibrosis, तो SNR cell का function, क्योंकि इसका structure function दोनों distort हो रहा है यहाँ पे. तो pancreatic fibrotic SNR cells जो होते हैं, they will lose their function, they will chronic pancreatitis में फिर यही होता है कि there is loss of function. In acute pancreatitis there isn't any loss of function because SNR cells regain कर देंगे अपने structure and function दोनों को. Now chronic pancreatitis it's a prolonged inflammation of pancreas and destruction of the exocrine parenchyma, fibrosis in the late stage in destruction. Both अच्छा chronic में exocrine and endocrine दोनों involve हो रहे हैं, और fibrosis मैंने आपको बता दी यहाँ पे क्या हो रहा है, proliferation of stellate cells, and that's why there is proliferation. Incidence, do remember, it's 0.4% to 5%. And the situation chronic pancreatitis is because of the long-term alcohol abuse. There is long-standing obstruction of pancreatic duct either by calculi or by any neoplasm. It could be because of autoimmune injury to the gland. It could be because of the hereditary causes of the pancreatitis as well. So what happens in chronic pancreatitis? There is repeated bouts of acute pancreatitis that will lead to perilobular fibrosis, duct distortion, and altered pancreatic secretion that will lead to release of the TGF beta, platelet-derived growth factors, and that will lead to the activation and proliferation of peri-SNR myofibroblast, that is pancreatic stellate cell, resulting into the fibrosis of the SNR cells. ठीक है, तो ये सारा यहाँ पे फिनोमिना हो रहा है. आपको TGF beta and platelet derived growth factor दोनों चीजें मिल रही हैं which is causing accumulation and formation of the proliferation of the stellate cells and fibrosis, distorting the functions. मोर्फोलॉजी में याद रखना, क्रोनिक में जो भी चीज क्रोनिक होती है इट्स फाइब्रोटिक, और उसकी जो स्ट्रंकन हो जाएगा, एंड दैट विल एट्रोफी भी हो जाएगी, ड्रॉप आउट्स ऑफ द एसिनाई भी मिलेंगे इसमें. ठीक है ना, एंड ग्रॉसली द ग्लैंड. हेलो
मैम, टाइम ज्यादा ओवर हो चुका है.
बस 5 मिनट है, 2-3 स्लाइड्स हैं मेरे पास इसकी, मैं इसको ऐसे एंड नहीं कर सकती, इट्स लंबा टॉपिक है ये. देयर इज डक्टल एपिथेलियम मे बी एट्रोफी और हाइपोप्लास्टिक मेशो, स्क्वेमस मेटाप्लेजिया. ठीक है, ऑटोइम्यून में याद रखिएगा कि इम्यूनोग्लोबिन जी आपको मिल रहे होते हैं इसमें ऑटोइम्यून टाइप में. ठीक है, क्लिनिकल फीचर्स सेम है, देयर इज सिवियर पेन की हिस्ट्री मिलेगी. वन मोर थिंग टू रिमेंबर, ओपिएट्स एनाल्जेसिक्स ऐसे होते हैं जो इसको फर्दर एग्रीवेट कर सकते हैं. ठीक है, क्रोनिक पैंक्रेटाइटिस में देयर इज लॉस ऑफ फंक्शन एंड स्ट्रक्चर्स. अब ये वाली पिक्चर देखें, इसमें सिर्फ ये थोड़े से स्कैंटी एसिनार सेल्स रह गए हैं जो कि ऑर्गन, और बाकी सब की जगह क्या हो गया, देयर इज फाइब्रोसिस. ठीक है, अच्छा, व्हाट हैपेंस आल्सो, पैंक्रियाटिक कैल्सिफिकेशन. क्रोनिक पैंक्रियाटाइटिस में याद रखिएगा देयर इज माइल्ड टू मॉडरेट एलिवेशन ऑफ सीरम अमाइलेज, देयर इज जॉन्डिस, एंड उसमें आपको एलिवेशन ऑफ सीरम अल्कलाइन फॉस्फेटेज भी मिल सकते हैं. कैल्सिफिकेशन याद रखिएगा, इसमें कैल्सिफिकेशन है. Prognosis is not good. 20 to 25-year mortality rate is about 50%, and patient can lead into pancreatic pseudocyst formation. There could be exocrine insufficiency, there could be endocrine insufficiency, and diabetes mellitus. Thank you so much. This is a topic. I will upload the presentation along with a quiz. So you guys will be given 24 hours to read the, even 48 hours I'll give you, because it's a big topic. Read it again and again, and if there is any query, you can come to me. Thank you.
मैम मैं सेशन एंड कर दूं?
सेशन एंड कर दें, इट्स ऑल डन।